We're live from the Montreal Heart Institute Cath Lab. This is Dr. Lee with Dr. Robert Abram.
Hello, everyone. This is also Jorge, our fellow behind us.
Jorge Vivar Sanchez. We're with
Lucie, our super nurse.
Veronique and have the assistance of Dr. Raymond as well. So as you see, we're hard at work right now, so I'm a bit distracted. I apologize for this. It's going to be a very interesting case, hopefully that we will be able to share with you this afternoon. We've already started some of the work.
Can we see our slides, please?
And at any point now, we should be starting the slide. So again, last week, if you recall, the case I did with Dr. Doucet was also a surgical turndown. This week is another case of surgical turndown with a multi-vessel disease and LV dysfunction. Next slide. So clinical scenario, this is a 56-year-old gentleman that presented to a off-site hospital about an hour and a half away from Montreal in an altered mental state and multi-organ failure. He had elevated troponins, obviously. So the diagnosis at the time was a NSTEMI, either type 1 versus type 2. He has classic, at 56, he had classic risk factors such as hypertension, cholesterol, and
run through.
He was known also for hepatitis B, has a history of amphetamine and cocaine use and alcohol abuse. The patient basically was admitted with multi-organ failure, cardiogenic shock, acute renal and hepatic failure, delirium due to acetaminophen intoxication. Due to a predominantly cardiogenic shock phenotype, a TEE was performed, which then revealed a 20 to 25% LVEF with diffuse hypokinesis. Once the patient was stabilized, obviously medication, antibiotics, and all of that, the multi-organ had stabilized, multi-organ.
I'll take care of it.
Organ failure had stabilized. The patient was referred to the for diagnostic cath lab at his hospital. Next slide. Can we show the diagnostic angiogram, Audrey, please? Let me know if in New York you see the angiogram. Do you see the diagnostic angiogram?
Yes, we do.
Okay, excellent. Perfect. So as you can see, this is the RCA. It's a diffuse, long, significant. Leguminous.
So focus on this, okay, and then we'll take care of the rest.
Leguminous.
So give me this.
So it's a diffusely diseased RCA, mainly in the mid part. It's mildly calcified, and you see that the distal bifurcation is also disease. The interesting other aspect of this angiogram is that you see collaterals going to a distal OM. You see what is likely an OM3 and OM2. Next. We can skip this. You see that there's disease in collaterals left to right. So this is actually the main piece that you see. He also has multi-vessel disease that is, at least by angiogram, moderately, if not heavily calcified. We see it in two views, and we'll show you the next one afterwards. But go back to the RAO caudal. Let it run. No, le 15-25 de la gauche. So you see the distal left main with a disease prox circ, as well as a mid-LAD lesion around the level of S2. Next. You look at this now. It's a diffusely diseased LAD at the level of S2 and some tortuosity within the calcification of the LAD. Next. Again, you see the distal left main very clearly here, and the final shot, diagnostic shot. So it's a clear left main bifurcation that we have, distal left main bifurcation lesion that is also taking the mid circ as well as the mid LAD as well. Go back to this 40, yeah, the RAO crani. You can see the level and the extent of the disease. So can we go back to my slides now?
What's to note here is that the LAD has moderate calcification, like Dr. Lee mentioned, and it's also very tortuous. So if we're thinking about calcium modification therapies, we have to take that in consideration. Also, the circumflex look like it has a very severe lesion in the mid portion, which could be CTO with microchannels. Yeah, we see collaterals coming from the right to the marginal and the circumflex. And I'm not sure if a guide wire is going to go through. But so we'll take that in consideration as well.
So the main goal today is to really do as much as we can in terms of revascularization under Impella that you obviously see. So to go back to the slides, the patient was discussed with the Montreal Heart Institute cardiac surgery team due to the significant comorbidities that we outlined before. The patient was declined for surgical revascularization. Can we go back to my slides, please? So after a frank discussion regarding his clinical condition as well as his overall prognosis, mainly his cardiac prognosis, the patient then accepted high-risk PCI and was transferred to our center. Next slide. So procedural consideration, we initially had debated about the vascular access. Again, this is a distal left main bifurcation with multi-vessel PCI. So radial, subclavian, femoral. The one portion that we got when the patient was here, I don't have the image. We're having some issues transferring images from our packs to the live setup. We basically did a angio CT. The right femoral, common femoral, is occluded and hostile at the level also of the common iliac. And the left
OCT.
The left side, the iliofemoral axis was actually very good. We had a 6 millimeter diameter at the level of the common femoral, which would allow us to then support the patient. Guiding, we initially had planned on having aggressively supportive guidings. However, as mentioned in other live transmission, and I'm sure some of you are undergoing the same process, we're having issues with the production chain, and we were unable to secure 7 French either EBUs or XB. Obviously, I'm more comfortable with 7 French when we're doing bifurcation, mainly left main bifurcation. We also considered doing right heart cath to guide ourselves in terms of use of MCSDs, mechanical circulatory support devices, and also to complete and complement if we do need the LV support. The Impella-CP was used. I mentioned SADIT as an option, but it's really a single access in a patient with severe PAD. Next slide. So the interventional plan was to aim for complete revas, adjust the plan according to IC imaging using a MLD max OCT-based protocol, use LV support, especially in the case of unprotected left main PCI in a patient with severely depressed or dysfunctional LV function. And the LV support is also required for us since we're planning on implementing calcium modification. The plan was to start with the RCA and then move on to the left-sided system by addressing the circ. If we believe that the circ has a micro channel that we can run through, if not, the LAD would then be done subsequently, and we would finish all this up with the unprotected left main PCI guided by OCT. The plan is to start with provisional, and then if need be, 2-stent strategy. Next slide. So points of discussion. The points of discussion: calcium modification, IVL, atherectomy, bearing in mind that the LAD has some tortuosity in it. Bifurcation in the left main. Obviously, as you have all read, EBC main trial debated whether or not a upfront 2-stent strategy versus provisional was better. The conclusion was that I think initially a provisional strategy is quite acceptable. Use of mechanical circulatory support during high-risk PCI is something that the audience could query us on, and also calcium modification in such a patient. Use and need and choice for intravascular imaging, and also the choice ultimately and duration of antiplatelet therapy. Next slide. while my colleague is setting up for intracoronary imaging, obviously everybody knows this figure where the high risk patient, the high risk PCI, what some of us call the CHIP patient, is an intersection of three main domains. One regarding patient comorbidities, the other regarding complexity of the anatomy and adequacy of the distal targets, and finally the hemodynamics of the patient. Next slide. So just to bear in mind what we're doing today, and some of you are likely also doing within your own centers, such ineligible patient, surgical turn-down patient, especially those with depressed LV, as well as requiring left main PCI. This is Sokol and Al. It's a almost 100,000 patient registry that has looked at such patients with a subgroup of almost a bit less than 2,000 patients that have been deemed surgically ineligible. That is on the left side of the screen, whereas on the right side, Sokol and Al looked at in-hospital outcomes in patients undergoing left main PCI and comparing those that were eligible versus those ineligible. The yellow bar is the ineligible patient surgical turndowns, and you can see a 20% risk of death in hospital versus 5, and a 25% risk of cardiogenic shock versus 5%. So a 4-fold risk of death and a 5-fold relative risk of cardiogenic shock when you undertake such patients. Next slide. So this is the Naveen Kapoor that everybody has probably heard of or known, has undertaken like amazing studies regarding hemodynamic support and the equation that he put forth regarding mechanical support. We're seeing this more as a multi-system support process instead of just a circulatory or coronary process. Next slide. Ça marchera pas. So, ça veut pas.
Ouais, passera pas.
Est-ce que je peux avoir le guideliner 7? So there are many devices that are out there, as you know, ranging from the intra-aortic balloon pump to the tandem heart, to the Impella, to the ECMO. Next slide. The goal for us, unfortunately the slides didn't come out. So there was a recent publication, 2019, that looked at an analysis which showed us what would favor the use of MCS. And as you can see from the figure on the right side, when you have an unprotected left main disease, when you have a poor LVEF, when you have a CTO, and you also have a need for atherectomy, that is when the implantation of MCS is better. Next slide. So right heart cath, the importance of right heart cath is not to be understated. A lot of us automatically go for coronaries and shoot the coronaries and go with that. But I think the basis of our practice initially, especially in the early years, is really about
OCT
hemodynamic evaluation. So in patients that are very diseased, there was a nice review in European Heart back in 2022 regarding how to manage such patients, heavily high-risk patients. And clearly, I mean, it's not a guideline per se. I think it's a piece that is a expert opinion piece, but I tend to agree and would favor such an approach where right heart cath is required in such patients, especially patients with either single ventricular dysfunction or biventricular or high pulmonary pressures. So key parameters such as pulmonary arterial pressures, pulmonary arterial sats, right atrial pressures, as well as LVEDP and cardiac output are required. The reason why we believe that this is important, next slide, is that it will help some of us to decide whether to implant or not. Je pense qu'on peut s'arrêter là. Rentre le guideline.
Ouais.
Sur le guideline. So as you can see, there are many variations of such a score, of such a an algorithm, and you can see from the LVEF. Est-ce que tu fais le ring down? On le voit pas, nous autres, là? Est-ce que tu le vois?
Un peu.
Alors,
C'est
c'est un petit peu le
ouais.
guideline, une petite affaire.
Test? Okay.
Okay. So while Robert is setting up with the OCT,
Changez les paramètres, s'il vous plaît.
I'm just going to finish up the slides. So we are basically looking at
Injecté.
dynamic 400 ou 300?
400. Injecté.
We are looking at different
Okay.
risk factors and parameters at the clinical
Live
and
view.
technical aspect for us to decide.
Calibrate.
Next slide. The importance of the right heart cath is also important for us, not just as an indication to implant,
enable
but
pullback.
also if we do implant to help the weaning process within the cath lab. Some of the initial data, as you recall, especially in the PROTECT series of trials, juste attention, tout a reculé un petit peu. About 8% of patients were not able to be explanted within the in the cath lab after the high-risk PCI. So it helps in many aspects in terms of the indication as well as in terms of the weaning process throughout the PCI once it's completed. Next. So let's look at what we've done up to now. So this is we're getting close to the live part.
So we can show maybe the femoral angiogram.
Est-ce que tu peux montrer maintenant si
Femoral
le live
angiogram.
Audrey est parti ou on va attendre pour l'OCT. Reviens pour nous. Monte au début.
Yeah.
So
we stuck the femoral the left femoral artery under ultrasound guidance with a micropuncture.
Du début.
Yeah. And you can already see the cardiac output is very depressed just by looking at the blood flow. You can also appreciate that there's severe PVD distally in the profunda. However, at the level of the common femoral artery, the arteries are actually very clean.
This is the least disease of the two
vessels. The right femoral, like Dr. Lee said, is occluded. Next slide.
No, it sounds like
we also perform a right heart cath. Right heart catheterization demonstrated elevated right-sided pressures. So the RA was a mean of 9. The RV was a mean of 14, 48/3. And the PA, we had moderate pulmonary hypertension, 49 systolic, 26 diastolic, 34 average. The LV was at 101/7 with LVDP of 18. So the transpulmonary gradient here is 16. So we have a mixed pulmonary hypertension, both pre and post capillary. We also perform oximetry in this patient to calculate the cardiac output using the FIC formula. And the cardiac index is severely depressed at 1.3 liters per minute per square meter. 1.2. 1.2 actually. So it's even worse. So it's way under the 2 level, the 2 cutoff for cardiac index.
Just to add, the PA sat instead of obviously a PA sat below 55 is also one of the parameters to look at. Our PA sat was at 29, if I'm not mistaken.
Correct. Next slide. Next. We then inserted the Impella play this. So we inserted Impella always under fluoroscopic guidance to make sure that there was no perforation or dissection, that it was flowing freely. Next slide. We gave the heparin right after. We crossed the aortic valve. So this is just a standard Impella CP installation. Next slide. Next, yep. Here, though, it's very important that we're parallel to the spine and that we aim for the apex and we're free from the mitral apparatus. Important contraindications that we review prior to implanting the Impella include the lack of aortic regurgitation, lack of VSD or atrial septal defect, and also lack of LV thrombus. Next.
Which was all excluded by TEE in this patient.
Yeah. Next slide. Next. Okay, so here, play this. So we actually obtain a single access Impella. So you can see using the micropuncture needle, we puncture the Impella sheet around 2 o'clock. And then we advanced 6 and 7 hydrophilic 6 and 7 sheet.
Next.
That's hydrophilic. Next slide. And then we're able to advance 035 wire through this access site. And we decided to tackle the right coronary artery at first.
Next.
So the right coronary artery is probably the easiest lesion here to tackle, although it should not be underestimated. It's severely diseased and it's moderately calcified. We're able to predilate it with long 2.5 balloons. And we implemented 3 stents going all the way from the PDA to the Prox RCA.
Initially, we were debating whether or not we should cross the bifurcation as it is small and disease. Next, so we elected to do post-balloon stent. Next. Wait. So obviously there was really mild tortuosity, and which required a 5.5 guideliner support to deliver this 2.5 by 48 stent. Next. So we just obviously opened it, and as you can see, the distal bed will not look that optimal. Next. So the decision was made to cross the bifurcation. Next, minute stent. Next. So we implanted a 2.5 by 23. Next, which
you put it under stent. This is 3038 on the Prox to mid RCA.
Next,
we post dilated with the stent balloons. Next,
vas-y à la fin.
Next.
So it was a 3.0. Next, vas-y à la toute fin de la droite. And we'll show you the final results.
Okay, 40. So this is the final result of the RCA. We're pretty happy with it. There's still a lot of disease distally, but the main vessel beds are open. You can also notice that there's collaterals going to the circumflex and the marginal. Okay. So we hope we'll be able to revascularize that.
So now you're all up to date what we've done up to now.
So the other thing to note is I don't know if you can see the aortic pressure, but it's almost like a flat line. So the Impella is mainly the device driving this cardiac output. There is a bit of pulsatility, obviously, but the waveform is actually very narrow.
Yeah, the pulse pressure is narrow.
Yeah, and the other thing is the PA pressure did not increase. So we're actually sitting at 47/21 with a mean of 34. So we're exactly at the same PA pressure as we were when we started this procedure. So now we perform OCT of the Prox LED and the left main in order to decide our approach for this.
We're having some technical issues regarding connecting for the live feed of the OCT. Do you see the OCT? We're putting a camera in front, so you're seeing it right now. So yes, maybe start. Excellent. Maybe start from the beginning at the run. At the start, at 0. Yeah. So as you saw initially, we tried to move it without with the JL. However, that was not possible. So we ended up having to put in a 7 French guideliner, which helped us deliver the OCT. As you can see, there's a lot of fibrous lesion, but now the calcium is starting, and we're more in the proximal portion. I think at the level of the left main, but in the LAD itself, I was actually surprised.
Mm-hmm. The guideliner.
Yeah. So okay, maybe go back. Go back.
8, we see at 5. Right. You know, there's an area that's very critical.
At 10.
No. Is that so?
No, that's okay. Recule. Va at 10. Okay, so it's just an artifact. So what's the level? The mean. So if you see, it's a mean diameter of 3. So that's not EEL to EEL. It's actually intraluminal. There. This looks okay. So maybe can you play with the axis so we see if that's one of the septals? At the level of 10, yeah, move that around. Is that a septal? So we have a lemon. So if you look at the longitudinal axis, this is quite helpful. So we see that the circ is there at around 30, but it's diseased and calcified. Maybe go the between maybe at 25. That looks like a a disease-free segment of the LAD. Amène-nous à 25 à peu près.
So the LED in the prox segment measures around the mean diameter of 2.9, 2.5 by 3.3. I think there is a bit of disease here, but not that calcified, meaning fibrous.
So surprisingly, there's not a lot of calcium. So it's fibrocalcific, but nothing that would require us to do
node ablation or
exactly.
orbital I think we can start with non-compliant balloons based on this, maybe 2.5 or 3.0 balloons.
The left main bifurcation around, I think 30 is where at 28 or 30 is where the circ is. So we need to see if we have to prep that lesion.
Measure the distal left main.
Yeah, so this is severe. If you go back.
Go back 2 frames. Two more.
Encore.
There. A bit more. A bit more. Okay, here. Measure this. So this is the distal left main right at the ostium. And what's the pinnet?
I think that's even the ostium of the
So we have an MLA of 3.87 and it's a 1.4 by 3.5. There is like calcium you can see at 7 o'clock. It's referential. So we'll see if we need calcium modification for this. But I think for the LED, we tend to overestimate the calcium by angiogram in this case.
Okay. So go to the left main so we can measure. Est-ce que tu peux aller à 40, s'il te plaît? So, that's perfect. So if you're seeing right now, it's where the left main is, the prox left main, where our guideline was, if you recall the angiogram. And we have a 4.0 mean diameter and a max of 4.5. Again, this is intraluminal, so I think a 4.5 stent could be something that we can consider. Go to 25. About. So that it's a 3.0 mean diameter. Can you go to 20? Why? 3.0. So we can plan for a 3. I think if we have the Megatron, I think, which is a 3.5, we can under deploy at the level of the LAD, which can then go and accommodate that 4.0, or we can do a 3.5. It's a length of about 16 to 18 in terms of stent. I think if we look at the left main, if you go back to 40, you have a mean. So pretty much any stent will go all the way up to 5.75, irrespective of the brand that we have, except for the Megatron that can go all the way up to 6. So the worst comes to worst, we have a 5.0. So I think we should be fine. Let's just go back to 10. This is us thinking out loud live. So I apologize for some of the delay and the inaction. So some of what we see, around there. Yeah.
It's probably like around 2.5 to 3.0. Probably around
so we're beyond the prox LAD. We're actually at the level of that S2, which is diseased. I don't know. Montre-moi la run d'OCT, s'il te plaît. On l'a sauvé en géographique jusqu'à où? Avant
ça. Yeah, play it.
Non.
41.
Celle-là, oui, laisse celle-là jouer. So the OCT actually didn't enter. We couldn't manage to send it all the way. So
we should take, I think, a 2.5, 20 or long 2.5 non-compliant. Start with that.
So based on this, what we could do is leave it here and then see. So the other plan that Robert and I discussed was to see if we needed to do the circ. Obviously, the plan is ultimately to have complete revas. The circ, as you can see from this angiogram on the upper edge of the is quite calcified.
Non, nouveau.
Est-ce que tu veux qu'on essaye de passer la circonflexe?
Yeah.
So we're just gonna very quickly attempt to see what we can do with the circ. If we see that the circ is more of a CTO recanalize CTO. The plan for us was to complete the job of the left main LAD, RCA, and then bring him back out at a later time to do the CTO.
Puis un sillon bleu.
Ouais.
Sillon bleu.
Ou...
Sillon bleu pour commencer.
Ah, tu veux essayer avec le sillon bleu?
Ouais.
Okay. So right now, we're gonna
try to wire the circ, see if it's a CTO or not. We're going to try with a sillon blue. And then if it's a CTO, we'll bring him back. If it's not a CTO, we'll do the bifurcation.
We'll try a couple of wires and see how it goes.
Yeah.
After the Xi'an. And after that, we'll move on to the PCI. Hein?
J'enlève le guideliner.
Oui. Parce que pour l'instant, on ne pourra pas avec deux guides. Tu nous remettras en 15-25. So, as you saw, we were using the 7 French guideliner inside of a JL to provide us with much more support. And the OCT helped us guide what we were planning for left main Prox LED PCI. However, it wouldn't advance despite having that 7 French guideliner in place. Right now, for the time being, things are actually pretty stable. We just had another PA measurement, and the PA mean was at 34. It's currently still around 34. I think you can see. Can
you show me the...
It's pretty stable for now. Oh, there you go. This one.
Just give me a signe.
Je pense que c'est sorti. Ouais, c'est correct. ACT dans 15 minutes. As you see right now,
it looks,
how does it feel?
Well, it feels like a CTO. I mean, the wire is not progressing.
Okay.
And the wire is not progressing at all.
Okay. Not there. Est-ce que je peux avoir
sur un fil 2?
Yeah. Fil 2 XTA. So an XTA and so an XT, which is not as tapered. It's still around less than 1 gram, but it's the polymer jacket and the artery itself since it's somewhat calcified, and you can see from this live injection, that it's probably a recanalized, heavily calcified and recanalized CTO.
Yeah.
Maybe we can do another view. Tu vois, scopie? Just going to show. Vas-y, fais signe. Yeah. It's heavily calcified, so we'll see. We'll see. Veux-tu que j'essaye?
Yeah.
XTA.
Au début, puis on change.
Il n'y en a pas?
Après.
Du tout?
XT,
okay.
Sinon.
Okay, so we again are running out of XTA. We'll try with the XT. XT. And if not, we'll give it one last try. For example, with the 2 other wires I'm thinking of right now, the XT. The issue with XTs, it tends to knuckle very easily and go subintimal, but we'll see what we can do with what we have, fortunately, and then maybe try either the next 2 before we move on to the LED. For the LED and left main PCI would be the Mongo MG14 with close to 4 grams of hip, and also a Gaia Next 2. I'm just going to attempt this. But at least you saw, which was quite reassuring for us, and it helped us guide the level of aggressiveness in terms of plaque modification. To our surprise, there wasn't much in terms of need to might need a better curve. Test. Yeah, I'm going to put an extra curve, which is not ideal, but we have no choice.
So we're still trying to see if we can get a wire across the circumflex. Because at this stage, the LED to left main, we're thinking that won't require calcium plaque modification based on the OCT. It will definitely make our lives easier if we don't have to tackle the circ today. But we'll see if this wire goes. Patient is very stable. The PA pressure is also very stable.
Yeah, it's not ideal. The thing is, I could rewire this proximal aspect
Oh, you got it.
with.
There's a huge chunk of calcium right in the mid portion. That's where my strong blue was actually getting stuck. The filter is making progress.
Yeah. Yeah.
It's hard to say. We don't have contralateral injection, although we could put one. If
we could.
Yeah, it looks like it's in a marginal. It's hard to say.
I think we're through. Peux-tu jouer celle avant? Okay, prochaine.
Il y a une autre branche qu'on n'a pas.
Ouais. So this is the one.
I think
Le
you're
numéro en 13-26. So we'll see what we 13 gauche, 26 caudal. Ouais.
Je peux faire ça. T'amènes exactement.
Est-ce que tu es capable de nous faire un roadmap?
Ah, tu vas l'avoir. Non, regarde.
OK.
T'as pas besoin d'injecter, t'es déjà dedans.
Est-ce que tu l'avais, le roadmap de tout à l'heure, l'image que j'ai prise? Ça, c'est sur le roadmap par rapport à l'autre. So we're using actually the Philips.
Ouais.
Ah oui, OK. Ouais, vas-y, Ciné.
We see that this.
I think we are through. On a des collatérales.
Ouais.
Est-ce que je peux avoir la fluoro, s'il te plaît? OK.
You can see the roadmap on the top right corner.
Cine?
Yeah.
I'm going to use Cine. Ideally, obviously, have dual injections when you're doing.
So you're connected with the other collateral.
Okay.
So that's very good. Let's maybe start with a small balloon and do the circ first. I would do the circ first, get it out of the way, then deal with the LED, and then deal with the bifurcation.
Which was the plan.
Yeah.
So do we have a sapphire, un saphir 1-0?
So taking the smallest balloon we have in our center, which is a sapphire balloon. It's a 10 millimeter balloon. It's a good balloon to start with the CTOs.
So this is debatable now whether it was actually recanalized or heavily calcified.
Maybe it's recanalized. Yeah, maybe
it's recanalized.
We'll see how the 1-0 goes, and then bring also
1-0-15.
Yeah.
Est-ce qu'il y a quelque chose de plus court après le 15? C'est juste 15 qu'on a? OK. Approcher 1.25. So ideally, we try to recoup as much as we can in terms of beds here. So while we've been working, the nurses have been telling me that the ACT is around 300. So we're actually
Very happy about that.
pretty happy under Impella. One of the issues at some of the centers, those of us who do a lot of Impella, some will put in the heparin in the bag. From personal experience, having done this quite a few times, this actually leads us to have an overshoot of the ACT and bleeding complications. So what I usually do is ask my perfusionist to come in and remove the heparin from their infusate. And we just basically go with the heparin that we control. Now the balloon is going in and it's through. So many things that we can do up to now at this point is obviously balloon. You see the chunk of calcium.
18.
Est-ce qu'on peut apporter un 1.25? Vas-y. And if we had any issues with
20.
dilatation, getting the angioplasty performed here in tight calcified lesion, then we can
20.
upsize obviously the balloon, or we could even do granuloplasty, or this would likely allow us, such a lesion would allow us to bring down a microcatheter and switch out for rota. Okay.
Un ballon 1,25. Sinon, ballon 2,015.
So this is good news. It's, despite some of the issues we'd have with equipment, some of the aspects that we needed is actually the Sapphire helped us out. And again, working with the kind of support that we have, obviously in heavily calcified lesions, we have a 7 French guideliner ready to bring down at any point if we're seeing some resistance, especially for after. And also we have that guideliner.
Yeah, take it.
That guideliner 5.5, if we wanted to, in isolation, do the circ first, managing it. So again, I think if we, est-ce qu'on peut jouer l'ancienne image de la gauche sur nos écrans? Est-ce qu'on a pris une shot de du 15, un 15-25? Joue-nous la plus récente, là. Oui. Laisse, ouais, mais laisse celle-là, laisse celle-là. Celle-là. If you're looking, je peux avoir des compresses mouillées, s'il vous plaît. So the prox circ is not diseased per se, obviously. It's not perfect, but from this, it's an open angle. It's not a closed angle. So this is quite reassuring. If we were talking about two stent strategy versus a, okay, tu peux laisser, Aline. Okay. A provisional strategy.
So we're going up now with a 2,015 balloon. I think it's a non-compliant.
And it went right through.
You went right through. So probably not a real CTO, maybe a recanalized, but it's going very well. I'm at 20 atmosphere.
Oh, what?
Open. Oh, it's very open. Nice. Okay. So easier. Again, we were preparing to go to war, but so far
always the same.
It's been smooth sailing, you know? We never know when a storm is coming. Go back. On 20 atmosphere.
So you see some tortuosity around the calcium itself.
Very good.
So I would be tempted right now to switch out the wire and do maybe an OCT run in that sort of train track calcium lesion to see if we just crack it or we need to do just as we had planned for the.
Do you have the Xion blue?
Est-ce que je peux avoir un guide de
Xion?
Oui.
Ciné?
Yep.
Just
yep, go ahead.
Oh,
nice,
beautiful.
All nice and plump. So right now what we're gonna get is a ballon 2.5. I'm gonna do a trap.
Do you want to just rewire?
Oh, we rewire? Okay.
Yeah, because it doesn't look too
okay. The Xion?
Yeah, Xion blue.
So what we could do one of two things: rewire with the Xion, and then do the OCT inside the lesion that we just ballooned, and also or do a trap, which I think should not be a big deal in this case for getting us down. As you can see, we've recouped a lot of oui,
Non, ben, on va voir.
Pour l'instant, attends.
I don't know. I think those are all good options. We'll see. I think it's probably going to be easy just to rewire. We didn't do any dissection re-entry or anything. Like I went very easily through the micro channels or
So
through a very tight lumen. I believe it's just going to follow the fielder.
When you look at the angiogram that we just displayed, one of the things that we have to consider is what to do with the distal bed. You saw the OM2 and 3 had disease. Peux-tu rejouer ce qu'on vient de faire? You see, so my temptation would be to just finish the occlusion and leave some of the distal bed
for positive remodeling.
Exactly.
I think they're going to remodel. They've been occluded for years. So I thought there's a bit of a knuckle.
Yeah. There's a well-known literature regarding CTO lesions that subsequently, you leave the bed to remodel, it will remodel itself. And I think this might be
That's it.
Better part of.
You're in a side bench.
Yep. I'm trying to, it was already a curve, unfortunately, so.
Perfect. Yeah, I think you can knock on.
Okay. That's what I'll do is we'll pull this one.
We're removing the fielder. Now we have a workhorse wire and we're ready to OCT.
All right. OCT.
And then we're going to stand the circ. Maybe do some plaque modification. We'll see.
Yep.
Then our plan is to do the middle AD. And then do the left main bifurcation. And maybe we keep it provisional. Maybe we do a DK crush or a DK culotte. We'll see.
So Robert, what do you think we'll find at OCT for this circ? Will it require?
I don't think it's going to require calcium modification just on the weight reactor on the 2.5 non-compliant balloon. I think it's fibrocalcific plaques or fibrous plaques.
Okay.
Again, I think maybe the calcium is extra vascular. Anyways, we'll see. The good thing is we take the guesswork out of the equation by doing intravascular imaging, and we're much more confident in our decisions afterwards.
You can also measure the distal bed, obviously. Est-ce que je peux avoir de la nitro? I'm going to give a bit of nitro here. Est-ce que les perfus sont là ou pas? Ah. Non, c'est juste me lire, c'est quoi les pressions que tu vois? 1 de nitro.
So the blood pressure is also higher now than what we started with, despite the sedation.
Pushing the nitro through. Thanks, Robert.
We started the pressure with like 101 in the aorta. Now we're at 120.
Dans 2 minutes à peu près, juste me prendre une pression pulmonaire. So as you can see, and this I teach my fellows when we do high risk PCI that don't require LV support, it's always good to have a right heart cath while you're doing it. Juste le reprendre dans 2 minutes après la nitro. You can always see how things evolve throughout the case. It's really a nice way to teach the fellows also the physiology that Kapoor and the colleagues have all shown in the past.
Just so you're very distal.
Yep.
Don't go
pull
off.
back. Yep. Sorry, my bad. Okay.
Let's go live view.
Push.
Calibrate.
Okay.
Calibrate.
So I was talking about the right heart cath doing high risk PCI, even in cases where you don't need
enable
to support.
Ciné.
Vas-y.
Correct.
So you sometimes see elevated pressures.
Correct.
And ça, c'est la nouvelle PA?
Yeah.
Nice. We finished it.
Let's see what the OCT shows.
So maybe now focus on the OCT while I remove the device itself. Sophie, juste montrer. Attends.
All right. So
Oh,
mainly
yes.
fibrocalcific plaques. Here we can see the balloons. So there's a bit of competition with the blood flow, unfortunately, in the proximal segment.
So there's a curve.
Yeah, but we
sure.
lost the signal in the third. We didn't have a proper injection set up. Unfortunately, we only injected 6 cc's. Go back at 25. Ouais, c'est pas
Non,
beaucoup.
on n'a pas fait de setup. Sinon, on peut le refaire. On peut le refaire.
I don't see any heavy calcium. It's mainly
Can you see the distal? Show
fibrocalcific
me the
plaque.
distal bed again. Go maybe at 10.
The mean diameter is 2.5. We went with 2.5. I think we can take a 2.75 or 2.5 stent. Take it, maybe,
2.5 cent, then optimize afterwards, and then maybe
Yeah.
repeat the OCT. What would be the, so unfortunately, we don't see the distal bed that much. It's 2.5. Wait, là. So this is probably us post balloon dilation. There's 2.2. So intraluminal is 2.2, so we can easily, yeah, here.
but I would
you could
tend
see-
to stay, it's 2.3 by 2.
Yeah, 2.3. So get
I
a
think
2.5.
2.5 is, we're
Yeah.
safe with 2.5.
So put that there, a marker, a bookmark there, and then go all the way to 25. So that's where the left main, we entered the left main. Maybe go less around 22. That's okay there. That seems okay. 275 should be fine. So we upsize out. So that's, how long is that? Remember bookmark? Bookmark? No. No. So around
2.7521 maybe.
Wait for it still bad.
2.5, sorry, 2.521. 2.520
stent 2, 5 par 22 à peu près. So as you saw, it's not that complicated. We were kind of eager to move on with the case. So we did the OCT with less optimal volume, trying to spare some contrast. Right now we're already at 200, but as Flaherty published in Circ, patients under Impella actually
Do
don't
better,
do badly in terms of AKI, risk of AKI. And sometimes if you don't use the right heart cath while you're doing them, the filling pressures are actually going down because the LV is all of a sudden, if you recall what Robert had pointed out at the beginning of the case, the injection in the femoral was quite very telling about the state of his cardiac output. So right now, his kidneys and his other organs have not seen such perfusion in a while. The goal is to really stent between OM1 and OM2 and stop there.
Yeah, to keep the place for bifurcation.
And move on to the LAD left main bifurcation. And again, all of us were, we were all getting ready for war. And this is always what we want, right? To be prepared.
Yeah.
And we're quite glad that what we saw right now has not led us to take out the big guns. My interest in doing OCT was to make sure that we would have optimal expansion, right? In the MLD max protocol, the first part to measure, to get morphology, to measure the length and measure also the diameter, but also the second part is to make sure that there's no main complications such as dissection, but also make sure you have well opposed stents as well as, more importantly, well expanded stents.
That's it.
We'll do a.
Look
there.
On here?
Wait. Yeah.
Yeah, we'll take it.
Yep.
On. And
it's well expanded. There's a little bit of a curve. So it's tricky.
It could be just a curve. 18 atmospheres.
Off.
Do you want to do the left main? For the
Sure,
balloon.
sure. It's a 2.5, but
Yeah.
we'll just open it up.
Just is going to make our life a bit easier after.
Non, mais c'est parce que là, on va injure the prox circ. So we leave it?
Leave it.
Yeah, just don't.
Okay.
Okay, ouais. Parce que si on fait ça, on se lance.
Let's go do the LED.
Yep.
I think at this stage. Ballon 275 non compliant.
We're going to have a quick look.
C'est
Sur un 2.5 distant.
Yeah. Okay. On va tout faire la distalité.
Ouais. Vas-y, je montrerai pour là.
Looks beautiful.
Beautiful.
Okay, great. There's this is actually
There's
looking
no
really good.
disease.
Maybe there's another lesion distally in the
Well,
continuation of the circ, but
it'll plump up and then we'll see. I think this is
We'll
more
bring it
distal and non-prognostic disease.
Yeah.
And we actually didn't see that before in the first images. Can you show us the films from the other center? The film from the other center, the RAO, the 15-25, the l'autre film. I'm just gonna take a quick moment to go back. So as you can see, we saw some filling, probably from the collateral from the RCA, but we never actually really had a direct view of that portion. Maybe show today's end result, the one that we just took, compared to what you just saw. I'm going to switch out and let Robert finish up the case. So it's really, so it's a big improvement. Est-ce que, on va faire l'OCT final, le circ? On l'a pas fait.
Yeah.
Okay.
Tu penses avec le colorant?
Ouais, on n'a pas.
Trois lignes d'épargne.
Ouais, 3. Ouais. Okay. So right now we're kind of happy with what's going on. We're debating whether or not we should do an OCT run.
I just wonder if the dye.
We'll see. We'll finish.
Maybe after the LED,
all of this.
We can do both, you know?
Yep. We'll get the LED done, and then we will set things out. And right before we implant the stent in the left main, we will likely make sure that everything is well expanded and opposed. The last thing we would want in this young gentleman with some of the comorbidities that I've outlined is that we had any issue with underexpansion and risk of stent thrombosis if there were any reasons for the DAPT to become discontinued.
Est-ce qu'on peut mettre le roadmap en haut à droite dans l'outil interventionnel? Do des checkmarks, Lucie. Crochet. Appuie sur les crochets. Okay. Déplace la table pour voir. Ouais.
So we're using the roadmap again from Philips, which will allow us to use less.
Minimize the dye, yeah. Here.
Yeah. That's the part we weren't able to OCT.
Yeah.
But judging, I can give you a little test if you want.
Right.
But judging from the circ, we're hoping that this will allow us, I think.
I would not go more distal,
Yeah.
but I wish my balloon would go a bit. Just like 1 or 2 millimeter. I feel like, okay, maybe go up here. But I would not stent more distal than that.
Unless we have a dissection, this 12. Those
2.5. So we already imaged some of the distal bed, not that distal, but we know we're around 2.5 millimeter.
Yep. Intraluminal. So with OCT, as you know, we can always get an increment of 0.70. Attention, lève.
Vas-y à 20 ici.
Non, t'as quoi son visage sur le... Non.
Vas-y à 20.
On.
So here more proximal nodes at 3.0, even 3.5 vessel. So I'm feeling
confident. Celle-là. Okay.
Very good
well
expansion.
Expanded. Okay. We're out.
We're going to do this area here.
Left main.
Verification, just to see how it reacts. It's going to dilate.
Bye.
Okay.
Can flow back to the...
That area was very tight. The MLA was 3.5. This is the left main. But again, the balloon has good expansion. This is only a 2.5.
We need to prep more, you think?
I think with 3.0 more proximal.
Oui, NC 3.0, NC 15. This is looking good.
Parfait.
Still diagonal that we could maybe. Yeah. Bon, nous, au tout début, le 10-40, we're just looking at our pre. De la gauche. Just going back to see some of the images. Il n'y en a pas? Est-ce que je peux avoir... OK.
Let's see the trio balloon. Let's see how far it takes it. So it's stuck there too, but I think I would go
Yeah, I
here.
wouldn't go that far. Yeah.
I would go here. There's a fat portion.
On. Un guideliner pas loin. 16.
Ouais.
I'm already calling out for the guideliner, thinking that we might. No. 5 points. 16 encore. 5.5. So we have two types of guideliner. The 5.
Let's go here.
Tu vas aller là?
Ouais. Just to open.
18.
It's tight there, huh? I saw that pressure. Peux-tu faire le tronc?
Ouais, vas-y. Bougez pas. Okay, I think it may have ruptured.
I think it ruptured.
Oh, I don't know if. Bougez pas. C'est 16.
The balloon ruptured. There's a severe calcium. Just make sure there's no perf. Looking pretty good.
Okay, so we have a dissection.
There's a big dissection, yeah, and that's
which is anticipated when you have ruptured balloons. We're stable.
So maybe let's just get a stent with a guideliner and get a stent distally.
Guideliner 5.5. Get down. 2.5 38 ou 2.5 plus court. Après ça, on va faire
plus court, because I don't think I can get it down there.
Okay, 2.5 20 autour de 20-23. So we're calling it for a not so long 2.5, maybe around 20-25, between 20 and 26, I mean, and then we'll see what we can do. And as long as we're stable, and this is where, it's important to really modify the calcium. We were confident that it was okay. However, there might be some small spicules and the balloon ruptured. So that tells us that at least in the extra plaque space,
this happened in the left main bifurcation. So we're already expecting.
So we're probably going to have good expansion. Always try to see if
I can go further.
Donne-moi le 22. Can we go further?
The guideliner is up there.
Okay, we'll see.
We don't want to inject anymore because we have a dissection.
So
we'll just use the roadmap to coordinate the deployment of the stent in the mid.
That doesn't work. Est-ce qu'on a un 2-0? On va me chercher un nouveau 2-0-15. Ballon compliance normal. Anticipating, it's always the same thing when you do work. You have a situation where right now the patient remains stable, as you can see from the pressures.
Pressure is actually higher than what we started with.
PA, and we have a balloon bursting at the level of the prox LAD and left main. The patient is quite stable because we're on LV support. So this is actually pretty good. We're quite happy with that. If you see the recent PA pressures, they've actually even lowered a bit. The mean went from 35, 36 to 31.
Let's see if the stent goes down.
The stent doesn't go. I've already called for a 2.0 so that we
I'm
can
getting no resistance, actually going very well.
Yeah.
So
the roadmap, I think we're happy with that.
Yeah. I would go here. It actually went further than my balloon. Okay.
Not to oversell one single company over another, but this is a Resolute integrity. I find that these are highly deliverable because of the cell design.
No, my guideliner is going in. It's
perfect. Okay. Okay. Tu voulais pas l'ouverture?
Ouais, sure. Okay, oui.
L'ouverture du stent.
Clear the stent.
I'm going to open up the entrance.
I'll go here. I'm inside the stent. We're opening out the entrance.
16. OK. Ça, c'est un 22. Maybe
So
take
just by
that.
measuring,
Since we can't do OCT, that's 22.
so we need a
Tout de
38.
suite.
Maybe maybe a bit
three-
shorter so we have space for the
3-0, and then we
bifurcation.
that left main to,
I'll do a 3032, maybe
yeah.
Megatron.
3-0, 3, non, c'est correct, regardez dans la chambre. Stent 3-0 par 32 ou 33. We're calling again.
Megatron.
Ou Mégatron, c'est pas grave, c'est pour
For the
le
class.
3-0 si vous l'avez en Mégatron. Sinon, on va prendre Resolute, là, si vous ne l'avez pas.
Resolute ou Megatron. Tout va bien, monsieur.
Ouais,
On peut mettre des compresses mouillées peut-être sur les visages.
On peut être mouillé froide.
Compresse mouillée, stat.
C'est. OK. So
we aim to
waiting
deliver
for-
the best comfort during the procedure for our patients. The patient is sedated, but he's a bit
Okay.
warm.
Est-ce qu'on peut avoir une pince
Keeping
hémostatique?
Very cold towels.
Juliette? Ou quelqu'un peut juste.
No. Where's the stent?
That is coming. Okay. Donne-moi le stent en attendant. OK. Oh oui, c'est cool. C'est bon. Non, ça, c'est notre ancien.
Merci.
So, Lucie, our scrub nurse, we were fighting the indeflator.
No,
We were stuck with much contrast.
we have people here that they work out quite a lot, and
Yeah,
they
right.
can.
What a lot of people don't know is Robert, I'm sorry to reveal confidential information, is a CrossFit fanatic. So he probably could have done this with his own bare knuckles, but we're letting him do the finer things. But after this, he'll likely go.
I'll go lift some weights for
yeah,
sure.
lift some more
sure.
weights. You don't need that much weight when you're delivering a 3-0. This is coming from a runner, not a CrossFitter.
We're both runner.
Yeah, Robert is a multitasking athlete. All right.
Let's see if the stent goes.
It should, hopefully. But again, it's a 3-0.
10 boosts.
We ended up having a Resolute, as you can see. I was
Wow,
hugging.
okay. It's very good.
We're going to do stent boost.
Stent boost, please. It's very good. I'm happy there, but I want to
I
stent
think
boost.
we might need to advance it maybe a teeny bit. C'est entre nous un petit peu plus. Ouais.
I pushed a bit.
Attends un peu.
Stent boost?
Centre. Attends, non, c'est juste parce qu'il y a une façon dont on voit un petit peu moins bien le. Yeah, c'est ça, c'est sur le mauvais segment. So that's a prox segment. We need to see the distal segment. Scopie.
Exclude the wire. Like this, yeah.
Pône un peu plus sur les côtés. Encore. OK. Yeah. No, we can pull back.
A bit, huh?
A bit. This spares us contrast. That's really.
I mean, I just want to. Sorry, the contrast came out.
Non, je pense que tu devrais faire un stand boost.
Ouais, on va le refaire.
You could move it a teeny bit, maybe
a bit
just a forward a bit, just a teeny bit. OK, that's good. OK, change-nous tous les paramètres standards. Je veux tout voir. Des cônes. Centre-nous, Lucie, s'il te plaît. Copie. OK. So we're at 14 right
now.
Get
the 325. We had 325 on the.
Yep. 16, so it's a 3.20 right now. Maybe.
And let's just do the.
Try to see if we can nudge it forward a bit.
Yeah.
Yeah. Anyway, okay, I'll go much more timid. This. Okay.
Let's do the bifurcation.
Yep.
you want to use this on the bifurcation, this balloon?
Oh, I'm not sure. It
Probably
might
not.
be too long. I don't want to stent the whole left main, so this is
Okay.
better for us to preserve. We might just lower the PSI and then do a gentle injection.
Let's give some natural ICC.
There's some EKG changes in lead 3. So we'll see if there's any pinched vessel. I suspect maybe the diagonal may have been
Test.
distal diagonal.
Let's see. It's possible.
Okay. Oh, so we have abrupt vessel closure right now. So I don't know if it's because of the left main. So again, we're under support. We're having a lot of.
Maybe just because of a lot of stent.
Well, I don't know if it's the distal bed or
is it a dissection that's proximal?
Yeah. Okay. So we go with a stent.
Yeah, I think I would go with a stent proximal.
Okay.
And then
we're gonna have to recoup this quickly and travel. Est-ce qu'on peut avoir un stent 3-5? On avait parlé avec le 4, on va le faire en
Non, 3-5-24.
Ouais, 3-5-24.
What's the alarm?
Est-ce que le perfus est là? Ouais. On a combien actuellement? So the pulse pressure has lowered. We have a systolic of 98 and 3.6 in terms of support. Le stent, est-ce qu'on l'a? 24 ou
Resolute ou Megatron.
Peu importe, Megatron.
I'm not sure.
Alors, Maggie, on a un peu de slow flow. Est-ce qu'on peut avoir le stent rapidement, s'il vous plaît?
J'ai besoin de seringue d'adénosine et verapamine. On va en prendre, s'il te plaît.
I'm sort of intrigued at what is happening.
I think it's proximal dissection.
Yeah.
Like I don't see our
dissection. The flap is there. So we're going to get rid of the flap.
Okay, go.
I'm just going to go in this. Pour moi, le 15-25, OK? On va le land. Le droit. We're going to land this quickly and then see.
Let's go quickly.
No.
Without Impella?
Yeah. So this is what we were saying, that you never know what happens in these heavily
the balloon rupture
proximally. Very diseased patient, and LV dysfunction. So we're going to use this as a way of getting us.
This is a 3-5-24?
Yeah.
3-5-24. Okay. No.
So we have the guideliner in place.
Okay. So you wanna
well, I think we have to cover the left main. Oui, on va prendre la Levo. Levo, okay. We're going to start. Fais un ciné. Néo 3. So we've covered everything?
No.
So we need a longer stent.
J'ai besoin de 3-5-28 ou 32. 3-5-32.
3-5-32. 3-5-32 rapidement, s'il vous plaît. 3-5-32. So. Éjecte pas, attends.
Okay. Yeah, because
so we need. Non,
non,
déployer. Mets-le en arrière pour qu'on se mélange pas. We need a longer stent. Rapidement. Go.
Pressure look up. We're putting a patient on level fed, and we are
so this is
hoping that
live as it gets.
Yeah.
So
real hoping that this is going to push away the flap and hopefully restore flow to the LED.
If not, then we have to believe that maybe the distal LED is compromised. So if it's not that flap from the
balloon
perforation, but balloon rupture, they might be the distal bed. But I think we sized it accordingly, and when we will see. Est-ce que tu peux mesurer une pression artérielle? So we're going to get some PA pressures. See? That's good.
Oh, wait, it's not going. It's at the stent.
So it's a curved. Let
me try to get the
you got it. You got it through. Yeah. Guideliner is there.
Yeah, guideliner is inside.
There you go.
Perfect. Right. Removing the guideliner.
So again, we've all dealt with this slow flow, left main PCI. Okay.
Let me just
listen it. I think we're good.
I would take it here.
Yeah. On. Yeah. So 12, 12, 3.75. Okay.
The ECG actually looks a bit better.
We still have no pulse pressure, but we're under support. And if I look at the Impella right now, we have 3.
Do you want to do the left main here?
Well, we needed a shorter balloon. We're going to injure the
Okay.
Je peux avoir un NC40, le plus court que vous avez.
8, s'il vous plaît.
Oui, ACT.
Ouais.
So we're just going to quickly
There's some T-wave inversions. Just a second, I'm going to do the ACT.
We're getting a 4.0 to optimize the left main.
Okay.
So it's back,
beautiful.
everyone.
Beautiful.
Garde celle-là.
It was getting hot in here, huh? I think
Robert might not need that CrossFit session after all at the end. This is while we're all working, Robert and I are sort of having fun talking. You all know this. There's a great team behind us, and then there's Dr. Raymond taking care of the patient for us while
thank you so much.
While Robert and I are finishing up the angioplasty and the nursing, and the techs are running around giving us the material very quickly. So we're very thankful, not just for the Impella, but also for the great team effort pulling together for this patient.
The question is, do we do something about the circ costume?
Yeah, we'll have to see.
We'll have to see. Maybe not.
We'll see the flow. Everybody knows the 2005 paper, the Korean group, where if there's TIMI 3.
On va diminuer la levo de moitié.
Tire un petit peu ton guide dans la circonflexe, peut-être un petit peu. Non, mais c'est correct. Si on peut. Okay, that's good. Where if TIMI 3 is there,
let's go here. Yeah, a bit back.
No, enter un petit peu. I'll go gentle.
We're dilating left main ostium. Distal left main, sorry, to the LED ostium.
It's going lightly with a 4.0 there.
This is where we saw like the tightest lesion on OCT initially. Let's pull back a bit here. Go.
Okay, size 16.
We're working quickly.
C'est un boost peut-être ou un signe? On sortit un petit peu.
Wait a second. Take it here.
Yep, we're good.
Now the patient is hypertensive, so it's a good problem to have in these circumstances.
And from a physiological perspective, you see that the pulse pressure has returned.
Yeah.
So we're quite happy about that. So if you recall, the initial OCT allowed us to really size this balloon. Intraluminally, we had a mean of about 4. So this is actually pretty well.
I believe it's well expanded. We'll do a final OCT after. Now let's give 1 cc nitro because we.
Juste 2 secondes. Juste. Wire.
Yeah, okay. The circ?
No,
that's the circ.
That's the circ.
You're pulling on the circ.
Yeah, no, it's parce qu'il y a.
It's in a little.
Yeah, little branch.
In a little branch. Okay, let's just do 1 cc nitro.
Nitro now is. Non, on va prendre d'autres nitro. Non, il y a du caillou dedans. Il y a du caillou. So,
okay, let's give some nitro.
On va prendre d'autres nitro. Oui. Oui, il est en train de se flasher. We're quite happy.
I will not touch the ostium of the circ.
So let's do a RAO cranie. to see what's going on in terms of that distal portion of the LED. The EKG changes, as you've noted, have subsided. Copy. Oh no, we leave it.
Next time. There's a diagonal that's
Maybe
slow
we
flow.
could, maybe we could try
do
to
something.
poke it and just open it up. So maybe we'll, instead of we could pull,
You want to remove
make sure we don't crimp the stent in the left main.
Do you want me to remove the wire from the circ?
I think I'm happy with
Circ, yeah, I will not touch it. I think the ostium looks a bit diseased, but
montre-nous le 15 le plus récent. Avant celle-là. Non, après. Celle-là, laisse-la jouer. So we'll see. We'll see. Right now, flow seems there's a lot of disease in the circ. We start
maybe. I'm going to take the wire from the circ. I'm going to bring in the LED.
The circ
is a cyan blue.
Okay.
Take it out, just under fluoroscopy, make sure it doesn't.
Don't crimp the stent. You want to use this wire or a different wire? Okay, 1040. I think it might be damaged, so it might be.
Yeah, I think so.
I would.
Let's remove. Let's take a cyan black. What do you think?
I don't mind for that. I usually try workhorse first.
Okay.
If that doesn't work, then we switch out. So it's not a big. Wait, cyan bleu, on peut poubelle. Wait, poubelle.
I'm going to remove the guard liner because
right now. Mais qu'est-ce que tu as sur la table? Is it a note run through?
Not run through.
Run through. We're going to get it through. See what we can do regarding. Celui-là. Tiens, je laisse ça pour prendre.
On presse des serviettes bleues.
Lève-là. This is a live show, so we're going to keep it clean, right, for everyone's enjoyment. So right now, we've switched plans, and we're heading to recoup that second diag.
This is 285. We're happy about that.
Peux-tu nous mettre le 1040 le plus récent, s'il te plaît?
En référence.
En référence, puis roadmap. Non, le plus récent à la toute fin. Ça, c'est... Vas-y, là, à la toute fin. Le dernier 1040 dans ta liste. Laisse ça. Here, I'll let you. The run through is
it is my favorite horse. I'm not gonna lie.
Robert's favorite workhorse, and it actually goes pretty much anywhere. The tip is not polymer jacketed as other wires, such as, for example, other workhorses like the BM2. It will go through. It doesn't have a tendency to loop. Such as the BM2 family or Pro Water, such other workhorses. However,
this is good. So
this is what you want. You're crossing into the stent. And
I don't even know how. I don't even know how it got in there so easily.
So is it the man or the wire? Ballon 2-0, s'il vous plaît.
I believe
take a 2-0. It's a combination of both. 12.
So one thing is sure, every time I do a case with you, Hong, I'm happy I had my morning coffee and my 8 hours of sleep. Because I would, if I were under a headspace, I would be rushing a lot more.
We do these fun cases together. So this is funny. We're having fun.
Very nice.
So
do a tap?
Well, we'll see. I think what we could always do is just open it up. Or some supposed to do a DEB and see flow. If flow is fine, I wouldn't.
Régulier.
Régulier.
2-5.
2-0-12.
Good.
I would just open the ostium and then leave it at that, and then repeat the imaging to see the level of apposition and expansion.
It's a very big diagonal, so I think it's worth fighting for.
And sometimes what we have a tendency is to look at a vessel's caliber. However, we all intuitively think also as the level of the myocardial jeopardy. And this territory is actually a larger territory. Attention, tu recules un petit peu. At the level of that second diag, and since this patient has a poor LVEF, whatever territory we can recoup and maintain, we'll do it. So that's what we've done up to now. C'est quoi le bruit? Non, c'est pas ici. C'est ça.
Open. It must be the wire.
Nah, it's the man. It's the man. 14. We'll just
Good
keep it on
expansion.
for 30 seconds so that we recoup that flow. Hopefully, we might not need to do much more.
Okay.
Okay. So we'll do less than 30 seconds, but I think it'll be fine. Le deuxième sort du corps.
Natural 1 cc, please.
Est-ce qu'on a de la nitro?
On a la nitro.
Pas trop de sang. On est en train de mal. OK.
Pushing. Okay.
Gonna wait a bit.
I think we're gonna probably need to stand. That's my bias is telling me we're gonna need to stand, but let's see the flow.
Provisional. All right. Let's do this and see.
Oh, actually.
Okay.
Want to do drug-eluting balloon?
Yeah.
What do you think?
Yeah.
Maybe do a LEO cranial?
Yeah, that's where I'm already headed. Great minds think alike, so we've already. C'est quoi le bruit?
Small.
Yeah, I'm not unhappy with this. I would tend to leave this.
Yeah, I think
yeah, it's a 2-0. It's a 2-0. I wouldn't stent necessarily. The flow is comparable.
Yeah.
I would just leave it.
I think let's leave. Let's do OCT.
Yep. Okay. OCT.
And then let's
pull the wire.
Yes. So you don't want to keep it for marker?
Okay, we can keep it. We can
keep it for marker. Okay. And that's a body wire.
Hopefully we'll be able to pass the OCT.
We'll see. If not, I'll remove it.
But we've optimized and most likely oppose the stent at the level of the entry, the distal left main.
Yeah.
So we're coming to a close to the 2-hour time slot that you've allowed us, and we sort of cheated, asked an extra 10 minutes because we had technical issues with some of the material, but hopefully we'll be able to show you the last OCT, and then we might end up looking at the circ.
I think the key points in this case were, proper preparation. We did an angio scan of the lower extremities. We had a cardiac consultation. We also had a heart team discussion about what's best for this patient. And we came in with a plan, despite the peripheral vascular disease. I think single access Impella is an attractive choice with pre-closing. Otherwise, this is not going.
Yeah,
it's the same issue here.
Same issue again with. Yeah.
Should I remove the wire?
Yeah, you might. Okay, just remove the diagonal wire. We'll see.
Let's see.
Move. Le retrait du guide de la diagonale. Retrait, Tania. Mais sec.
If not, we'll put the guide liner again. Our guide is a bit short, and we're always
biasing us upwards. So this is a bit more complex in terms of.
Okay, let's get the guide liner.
Okay,
I don't think
I
can push this OCT through.
I don't want to damage the OCT.
The other key points always, I think, use the right heart cath for monitoring and also decision to mechanical support in those cases.
And recall that, we had the RCA was fine, the subocclusive our circ was fine, the LAD was fine, but then we had that balloon rupture at the level of the prox osteal LAD distal left main, which then, as expected, led to abrupt closure that we would probably have not been that coy and calm, though efficient during the PCI if we didn't have support. Vas-y doucement pour pas endommager. Peut-être prendre un ballon.
Ouais.
Est-ce qu'on a un ballon? Recule-le. Est-ce qu'on a un ballon 2-5?
Mais tiens,
ça rentre? OK, parfait. It's
Okay,
entered. OK, perfect. OK. So the 7 French went through.
Yeah.
Mais juste ça. And French went through, and we're going to get the OCT going. We could always, again, as you all well aware, as we along the cases, the guidings warm up. As they warm up,
they go from being past al dente to not al dente.
overcooked.
Very overcooked.
Our guidings over time get overcooked.
You want to help me?
Yeah. We're going to get this OCT going, pulling back a bit of the 7 French. Là. 7 French.
I think it's kinked.
Oh, so maybe. Oh, yeah, it's damaged.
Yeah, I think it's.
Yeah.
Do we get a live view? It's still good, you think?
Attends. Est-ce que tu peux faire un live?
Let's just try. I think
Faire un live. Est-ce qu'il marche? I don't see. Okay, so.
Should be fine. It just kinked a bit.
Yeah. T'es bien ouvert? Dévissé, je dis, excuse-moi. Yeah, it's a bit. Yeah.
I think I would take another.
Yeah, the problem is I think we don't have another. Let me see.
Okay.
There.
It's kinked. So every time, can you hold just the wire?
Yep. Yeah. Over the wire portion.
I think it should go because of the
voir le défib, s'il vous plaît, qui fait du bruit. Merci. Show us.
Here's our final OCT catheter. We hope it works because we don't have any other.
They're on the way.
It doesn't want to go.
Yeah, I think then we stop there, and we're at the level.
Unfortunately, we'll see only the
prox. Let me see
the prox, but
it doesn't want to go. Let me see.
No, it's just it's all kinked, you know.
Show me.
Mm-hmm.
Might be some sort of interaction with the guide liner.
No.
It's really tough to move this forward. I don't know how much live we have left. I don't know if anyone from the MetStream team can give us an idea of what we have left in terms of timing. But we're going to nudge our way through. This is pretty much it, I think. Pull back a bit. Yeah, no.
It's not going to go on.
No, it's not going to go.
But we get to only see the left main.
We'll see if it's damaged and we switch out to get an IVUS. We have obviously for complex PCI, we always want to be sure that we get to see the left main.
Okay, let's
go live. Do you see anything? Il accroche.
Non, mais il y a aussi kinké.
Attends un peu. Je peux faire un petit test. Attends, je fais un petit test, Robert. Bring down. Okay, that's good. All right, bring down. Go whenever you're ready. We'll see.
Don't inject the whole thing because it's so
No,
short.
for sure.
Actually, okay. Go. Okay, that's it.
Okay, we didn't inject the whole 16 cc's. We'll see if that position at the level of the left main is fine. We'll go see if you can go focus on the, if you can focus now on the OCT, we'll see. And we could always pull out a an eagle eye.
Yeah, eagle eye would be good.
Est-ce qu'on peut approcher la machine pour le eagle eye?
Let's take the eagle eye.
Oui, le
Eagle eye.
arrête ça, Lynn, je reviens. So, est-ce que on peut, Sophie, tu peux focuser ou quelqu'un focuser sur l'OCT? So we're waiting for the camera to switch towards the OCT. Unfortunately, right now.
Okay. On va prendre le eagle eye. Je pense que le cathéter est endommagé.
Ouais. Unfortunately, it's not what we.
On ne peut pas l'avancer plus loin.
Ouais. Est-ce que le eagle eye avec la machine qui est là, ça revient? So we're gonna pull
on n'a pas besoin de eagle eye, on le met directement.
OK, parfait.
Pas le HD, je veux le eagle eye.
On a fini avec l'OCT. Est-ce que Sophie est encore live?
Are we still live?
Sophie, est-ce qu'elle est partie? J'entends rien. Est-ce que Sophie, elle est là? Est-ce que c'est fini? J'entends rien.
Personne n'a rien dit.
Personne nous répond. No, it's actually very good.
It's very high.
Very
it's
high.
Hypertension, my friend. Give him some Norvasc.
Eagle eye.
The pressure low is the PA pressure. PA pressure is actually lower too.
It's lower. Everything's
good. It's going in the right direction. Don't scare me, man.
Yeah, you got to look at the right pressure. Or the fellow was wondering if there was any low pressure, but it was actually better PA pressure. PA pressure is now at 40. We started at 49 systolic. The diastolic, if you recall, initially was at 26, and now it's 19. So we're quite happy with
All right.
Il se branche pas directement?
Non, mais Luc André, il se branche directement dans la salle, non? C'est sans la console. C'est le vis intégré dans la Philips. Regarde, c'est juste un petit plug que tu mets dans la machine.
OK, parfait.
So we just have some technical issues with our IVUS, but
so
hopefully we're done soon.
The OCT would not pass. So again, we have to think about if things don't pass, what we do. So I think in this case, we might get a 2.5 and bring down inchworm the 7 French down the LAD. As you recall from the RAO caudal, it's an angulated, upwards angulated LAD after the takeoff from the distal left main. Luc-André, mets-nous le 15-25, s'il te plaît, du début.
So, do we have the IVUS ready?
Est-ce que tu peux arranger le IVUS? Si ça marche. So, celle-là, non, celle où il y avait du contraste. Prochaine, avec le contraste. So you see the angulation. So when we come out, it might hit the IVUS, the portion of the entrance of the of the left main actually goes sort of an angle, and then the LAD as well. So this might be an issue. But right now, the distal circ, when I look at this, I would not tend to sort of try to go and recoup all of this bed and maybe follow him up. Oui, on a le cathéter. We're having.
C'est juste un plug que tu rentres dans la salle. Ouais.
On a une gaine d'écho.
Peux-tu chercher de l'aide? Est-ce que tu sais comment l'installer?
Sinon, donne-nous la machine.
Mais ça va pas dans dedans, je pense. This
C'est-
one goes
c'est-
directly in the room.
C'est pas.
I used it many times before.
Ouais,
There's
I
a plug
know.
behind.
So right now we're just getting ready. The OCT machine has been set aside, and our tech has to set up the hookup for the eagle eye. So interestingly, when you consider left main bifurcation,
Just see if it goes.
DES
I'll just try to see if it goes, you know, 'cause
first
if it
and
doesn't
second
go, we can,
generation, Rosota,
we'll do it in a little
Rosota and Al in et al. Around 2020 did an interesting analysis. Here, maybe do this in the meantime before. And they found that bifurcation obviously are worse. That's all. Obviously, and we all know this, have worse outcomes in terms of MACE. It was a 23,000 patient analysis. They did a sub-analysis of about 3,000 patients in left main bifurcation PCI with newer generation, and it still remains all the way up to 36 months with a heavy toll in terms of MACE rates. We're talking about 21% versus
Montreal, we will
12%.
have to go to the next live in less than 5 minutes.
Excellent.
Sounds good.
Okay. So we're having issues with this again.
What's this? What's the alarm?
So c'est l'alarme Amber Alert.
Oh yeah?
While we're working, all of our phones are ringing here in the province for an
Okay, we're gonna
Amber.
have to inchworm the guideliner.
Okay, we need a 2.5 ballon 2.5 12, s'il vous plaît. Puis Luc André, s'il vous plaît, appelez quelqu'un pour de l'aide. So as we're leaving, thank you very much for joining us for this almost 2-hour procedure. I think we're quite satisfied with what we have. Obviously, it's not as perfect as some might say, especially in the circ, but I would venture to say that this will likely help him more. On entend de la distorsion. So we're getting that balloon. So we're going to inchworm the 7 French guideliner into and throughout that angulation of the circ and LED, because we have to finish up the job with imaging for left main PCI, especially in patients that are prone to have lower output, obviously, in this patient. Once we remove and wean this, I don't anticipate anything major in terms of weaning issue.
No,
Right
and
now,
we're
support is
gonna
actually motor current is-
pre-close, so we'll
motor
bring
current is
Impella. I
good.
think the only issue here is that we don't have a contralateral access for now.
You can always check on
to check,
Doppler.
but we'll check on
Yeah.
Doppler. We'll use surrogate markers. But the patient is not very obese,
C'est ça,
and
c'est ça que-
we did a state-of-the-art stick, so I don't foresee any major issues.
Attends, recule le ballon. Oui, c'est là-dedans. Ça te prend une gaine.
Go on here.
Montreal, we will continue
Okay.
recording locally. We
Okay.
have to switch to the next
OK.
case. Thank you
Recule
very
un
much.
petit peu le ballon.
Thanks so
Thank
much.
you. Recule un peu le ballon.
Ouais.
Ouais, OK. C'est bon. OK. 6. 1, 2, 3.
Okay, off.
Oh, je veux pas.
Let me
Wow.
just try to get the guide in a better position. Okay.
So we're going to try that.